Hello, everyone. I'm Ron Rolfing, your host of the ACAP Preferred Vendor Education Series, and I'd like to welcome you to our latest session presented by InfoMC. Our panel today is Dan Black, Senior Vice President and Chief Technology Officer, Alan Daniels, Director of Clinical Solutions, and Harm Scherpbeyer, Chief Medical Information Officer. And they will be discussing beyond data flow, driving interoperability to streamline care and utilization across disciplines. But before I turn it over, I do have a few housekeeping items I need to take care of. This webinar, along with all ACAP calls and webinars, will be held in accordance with the ACAP antitrust guidelines. And these guidelines can be viewed on our website. We will be recording today's call, and we will post a slide deck and recording on our website by tomorrow morning. And the link to these items can be found in the invitation sent to you for this webinar. And please remember, if your plan is looking for a vendor, be sure to check out our list of preferred vendors on our website. Just look to the top of our homepage and click on the preferred vendors link. And you also can post a note or even an RFP on the preferred vendor connection portal. And of course, during today's session, you can ask a question at any time by clicking the Q&A icon on your Zoom window and typing in your question. And all those questions will be answered at the end of the presentation. Now, I'll pass it over to Dan, Alan, and Harm.
Thank you.
Thank you. Good day, everybody. I'm Alan Daniels, and I will be the moderator for this discussion today. I am the Director of Clinical Solutions. With me today are Dan Black, the Senior Vice President and Chief Technology Officer for InfoMC, and Harm Scherpbeyer, Chief Medical Information Officer for InfoMC and Health Analytics Faculty for the Jefferson College of Population Health. Our goal today in this is going to be to provide a brief content of materials, and the main format for this will be a discussion that I'll be facilitating between Dan and Harm to go over the relevance of this. We've tried to design the content today to be focused broadly so that it's applicable to a wide spectrum audience of expertise. So we're going to talk about CMS and ONC initiatives. We're going to talk about API infrastructure, the benefits for payers, providers, and patients, support for population health management. And as Ron said, please enter your questions into the chat, and we will come to those as we wrap up the final part of the discussion. So with that, let me turn it over to Harm and let him make his opening remarks.
Thank you, Alan. And thanks everybody for joining us today. So these four main topics, they are seemingly different discussion topics, but these are all four current trends and four current concepts that point in the same direction. So I think it's important for us to bring that together today. There will be more data exchange, more technology to support data exchange, more regulation requiring data exchange, and what that means for health plans and for healthcare providers. That means more options to include IT systems into your, what we call a stack, into your set of tools to help you manage the care for your members and for your population. So Wendy, let's move to the next slide. I would like to discuss these regulatory and government initiatives with you, and what makes this so confusing, both for me and for you and for all of us, is that there are so many initiatives. There are rules for payers, for providers, for electronic health records firms. They all have different starting times, all different target dates, all different phases. Some of these rules come from ONC, the Office of the National Coordinator. Some of them come from CMS, Medicare, Medicaid, as part of their conditions of participation. Different agencies, different enforcement mechanisms. This is hard. Also, this rule, the 21st Century Cures Act, was signed by Obama, so quite a while ago, and we're just now seeing the implementation of these phases going into effect. So that makes it so hard. But let's walk through some of these things and specifically talk about how do these trends and initiatives apply to you and your organization. Start with ONC, the 21st Century Cures Act. ONC is the Office of the National Coordinator. That's the office at the government that coordinates any IT, health IT initiatives, standards, rules, initiatives. So, and today, mostly about data exchange. There is a set of data exchange requirements for payers, for providers, and for electronic health records firms. First one I want to mention to you is TEFCA. It means Trusted Exchange Framework and Common Agreement. And to me, that means nothing, right? That is a very vague set of words. What does that even mean, a Trusted Exchange Framework? But in short, what this means is a set of rules, a framework, a set of rules and agreements, a set of standards that are meant for national data exchange. Today, we have health information exchanges in various regions. I live in the Philadelphia region, so our health exchanges is our health information exchange is called Health Share Exchange. These are mostly regional. TEFCA is a framework that will connect these health information exchanges and other health information organizations to enable nationwide data sharing. So from going from regional to nationwide. More important for us today is that TEFCA also pushes forward the use of the FHIR standard. FHIR means Fast Healthcare Interoperability Resources. It's a standard used by APIs, another term, and then in just a few minutes, we'll explain the significance and importance of FHIR-based APIs in our systems. So TEFCA is a driving force behind FHIR. The next term I want to mention here, which is also really important, is US CDI. It means US Core Data for Interoperability. I am a big fan of this initiative. And what it does is it defines and it requires a set of data to be exchanged by payers and providers. It says, if you start exchanging data between each other, this is the set of data that you should be including. That used to be fairly optional. Allergies, meds, problems. But now, under this US CDI rule, a lot more data is becoming part of the data set that providers share with each other, with the patient, and with payers. And that includes, for example, the patient notes. Visit notes, discharge notes, progress notes will now be included in the information that gets shared. I think that is really, really important because typically the note is the part that tells you the story about the patient. So if you're a health plan and you want to get information about where is this patient in their care, often you can see a little bit in their med list, but what you can really see is in their notes. So US CDI sets the bar higher for what data will be exchanged, and it will include narratives and patient notes. And that, to me, is a very useful initiative. The other part, the next part of the ONC rules, the 21st Century Cures Act, is the information blocking rules. I think you're familiar with it. It is a set of rules that makes it mandatory for health systems to share data with their patients. There are 8 specific exceptions that define when a health system might not be able to share data with patients. But outside of those 8 exceptions, the assumption is data is available to patients and patients have access to their data. Very, very important because it changes the assumption. The assumption is you have access unless you fall under one of those 8 exceptions, but the assumption is patients have access to their data, which really is important when you're a health plan to make sure that the families, the patients, their caregivers have access to their data and can be very engaged in their care. I mentioned FHIR and APIs earlier. This law also requires electronic health records companies, such as InfoMC, but also EHR companies, that they have to include these application program interfaces into their software. So every health IT company has to be able to support these APIs that allow us to exchange data, both to send data and to receive data from other parties. And that's, again, another topic that Dan will go into some more detail. And the last one on this list, on the ONC side, is payer APIs. Similar to providers, payers will have to provide a set of APIs, application program interfaces, that give patients access to their data, and also providers. And it also helps, these APIs also help us improve some of our processes. We'll talk about prior auth later. Prior authorization is clearly a transaction between providers and payers. And while it's done electronically, it's kind of done semi-electronically. And we believe with these APIs, we can move from semi-automated to fully automated prior authorization, which will totally improve the way providers provide care, and also how about health plans can help approve the tests that patients need. Those are some of the highlights in the 21st Century Cures Act from ONC. The next two topics from CMS, from Medicaid, they also have initiatives that point in the direction of interoperability and data exchange, and they specifically do that to continue the transition toward value-based care. One thing I'd like to highlight, because it just started 3 weeks ago, is the initiation of the ACO REACH program. ACO REACH is started January 1st, 2023. It's a program by which practices can directly contract with Medicare for at-risk, to be an ACO, to have an at-risk contract with Medicare patients. So in the past, that used to be done through an ACO. You have to first form an ACO or an accountable care organization. Now, practices can participate in those initiatives directly. MSSP, for example, is now open directly to practices if they participate using ACO REACH. So this increases the number of practices and providers that will start using value-based care initiatives, and therefore continue the shift away from traditional care, fee-for-service care, toward population-based care and value-based care. I am accountable, as a provider, I'm accountable for a defined group of patients, and I'm proactively managing that population for quality of care and reduced use of acute care. Whether the patient comes to see me or not, they're part of my panel, and therefore I am incented to provide the care for that patient. So I think it's a huge development that started just in January and helps us expand the amount of value-based care in our country. Another aspect of ACO REACH is specifically the inclusion of requirements and measures for health equity and social determinants of health. So that's another change in the direction of CMS to say this is not just about quality measures or utilization measures. We will now also start looking at equity and access, and including social determinants of health in that overall package of value-based care. So I think that's another twist that we see coming up right now with the ACO REACH program. So all these things, they all point in the same direction. Data exchange toward patient access, better communication between payers and providers, and increased use of value-based care. So that's the regulatory framework. Now let's echo that with the technology direction, and Dan is going to talk us through that. Dan.
Thank you, Orm. So just to level set, I know we've got a bunch of different folks on the phone. The API frameworks are basically the way the applications talk together. So these are application programming interfaces that allow for disparate applications to talk. Within those frameworks, there's a lot of different protocols or languages that they talk. Some of those languages you've heard before. People will say API or web service interchangeably. I think everybody on the calls has familiar or has heard of HL7. Well, HL7 is the basis by which that FHIR standard that Harm was speaking of was built on. And it was the idea that, as things evolve and it continues to evolve, we have 5 kind of main tenets that allow that API to both work within your environment and also provide value within your environment. So to work within your environment, there has to be some standards that are set. And those standards, like everything else in healthcare, continue to evolve. As Harm was talking about some of the security aspects of access to different information, the protocols, the language that they speak, needed to be adapted to be able to encompass that granularity of security. And this is all under the high trust CSF. And high trust gives an overview or blueprint for how within an environment not only do you need to protect the patient health information, but how do you protect and provide the access to that information to the parties that need it when they need it? So APIs continue to evolve. Again, what used to be driven by the need to get better efficiency within a payer organization or within a UM plan has evolved into more of a mandate similar to the 96 HIPAA mandate, where there were standards with the X12 standards that were put out there. The Cures Act is doing the same thing for more real-time communication. So what it's the way it's set up, it's got its rigors around ensuring that all patient data and patient-related data is secure, accessible, and when it's presented, has a quality of data that's better than the data that you would get today. One of the other benefits or offshoots of this, and being in pharmacy for a while where everything is real time, it was a challenge dealing with large data sets, but everything's starting to get broken down into value add components. And those value add components, there's 5 main areas that they address. One is efficiency. So how do I get that information from point A to point B? Innovation. So they can start to compose these components in a way that makes sense for the individual or the person using that information. That integration then leads to point number 3, which is personalization. So I can now set up a composable infrastructure with the APIs, bringing that data forward in a presentation that makes sense for that user. So for example, Arm was talking about the prior auth process. Well, the prior auth process may not need access to a lot of other data, and we can streamline what that end user is doing by orchestrating those APIs, and another term you'll hear, which is microservices, into a framework that is presented with what that user needs, when that user needs it, and it's not all necessarily there at the state, not all necessarily part of one application. The next piece, given the change, is future-proofing. How do we future-proof what we have today? And the evolution from HL7 to HL7 Fire has started to expand what is able to be presented to the end user. What used to be ASCII data presented in an XML format has evolved to now take on different message types. JSON being one of them. We've defined more REST-based services. REST-based is a standard by which you communicate with that web service. It gives you that overall kind of packaging, if you would, of how that service is presented from point A to point B. The W3C of the World Wide Web Consortium has been driving these standards, and that is another standard that came in both with REST and what they call RDF, which is the resource descriptions that are within that data, so that it is all standardized. So we keep talking about standards. Why? Because the quality of data becomes extremely important when you're having a transaction like this, to ensure that you have what you need and the quality is there. So what are we doing with these frameworks? We've got the common language. We know how to secure the connectivity. And now we're looking at the extensibility. So within each one of our environments, no matter what your job function, odds are you're interacting with an API behind the scenes at some point in time. If you buy something on Amazon, it's all API driven. Healthcare is moving in the same direction. If you click from screen to screen within Amazon, you are actually moving between applications, but to you it's seamless. Healthcare, from a kind of growth and evolution standpoint, is going the same direction. So according to McKinsey Group, 60% of workers surveyed saw that they could cut significant time, 6+ hours out of their week, if they would automate functions within their job. You start to multiply that by everybody that is in care delivery, and you start to see that this, even though including an infrastructure, the API infrastructure, the Fire infrastructure in your environment, may have an initial cost uplift, the efficiencies that it drives, the ability for you to have an environment that you can now rapidly scale, that the quality of data is better, and you ensure the security, really will pay off and does pay off, given studies in the long run. So a larger upfront investment in some applications that have or are either FHIR or API driven today. But when you start to look at doing that ROI for an implementation of a framework, you have to include other elements, which then get into user efficiency. And what is called in this area is also the use of software robots. Software robots look at frame, form, and function, what's going on within the application, what are you doing repetitively, and then they take that repetitive cycle and automate it so that it's no longer repetitive. If I click the same direction all 6 times, it will move the same direction all 6 times. Again, all enabled by that real-time information that's provided within that API framework. So this, from a prioritization standpoint, needs to be our priority. There's so much that is driven and can be driven by regulation within our environment, but unless we prioritize this, it's not going to be something that will move forward and continue the rapid pace. It's right now is the Cures Act has provided a lot of that fuel to get this moving, but it's going to take everybody on the call essentially to keep this moving in the right direction and provide additional value. Harm, did you have something to say? I'm sorry.
No, I hear you say that, and I'm nodding my head because I think that is exactly right. That is where we want to be. If the government provides initiatives and regulations, if the IT vendors like InfoMC and all the other ones have the function in place, the next move is really up to health plans and healthcare providers to start exercising that ability.
So
that's sitting there.
That's really my next question for you guys.
Go for it, Alan. Yeah.
Giving great overview of the material, but what's it really mean? What should health plans do? What should they be thinking about? What should be on their radar screen and in their shorter and longer term planning?
Yeah, I think that's the point of our discussion today, right? That now the table is set and the tools are there. It's now up to health plans and also separately health providers to make the next move. The incentives are there, the environment is there. There are some disincentives. So that's all about promoting interoperability, promoting sharing data with patients, and also promoting standards so that information systems can exchange data. In parallel, continue to drive towards value-based care, which basically forces, or let's say encourages, health plans and providers to change how they deliver care and how they manage their members, moving to manage populations, monitor high-risk patients. Care coordination is such an important concept of value-based care and population care. That requires information systems. It's not something that you do on your existing claims management system. So step 2 is what Dan talked about. EHR vendors and IT firms, just like InfoMC, we built these FHIR APIs into our systems so that they can both send and receive data from other systems. For example, if you're a health plan, you may have a system that manages your members, of course, and your claims, your reimbursements, but your system today may not be able to be very effective at care management and care coordination. Tracking which patients need a reach out from your care team. That's where you would use a care coordination system and plug it into your existing infrastructure using the APIs that Dan described. And that's the next step that we're kind of waiting for to happen now. Dan, what's your perspective on that?
Sure. It's been actually interesting to take things that were conceptual a couple of years ago and seeing them put into practice. Yeah. We do have a client today that they're looking at these APIs to support their member holistic view, so a 360 degree view of the member. So in one pane of glass, you can see all information about that member. We keep adding into that, as you mentioned earlier, with the SOH measures that are continue to evolve. they become plugin components at different parts of that care continuum. And we're seeing more and more where that needs to be enabled. And I'm seeing, and we're seeing from telephony systems, full member view, claim status, interaction with different types of criteria, stratification of your risk levels if you're on the payer side, using engines that are you can pick who you need to use. So you're picking best of breed for the function, not a monolithic deliver all from one system. One other benefit that really comes out of this is we've got users with multiple systems, and those users are switching back and forth, trying to get this piece of information and move it over from system A to system B, having multiple screens open. And the approach originally for that was this kind of monolithic structure or an application that would do everything. It's now kind of going the other direction. It's breaking down into best of breed components that are supporting both the care coordination, but now we're seeing more and more where they're supporting digital health or self-service health.
Great. Harm, anything you want to add to that?
No, I agree. I think what Dan also just said is noticing broken workflows, noticing workers who need to use multiple systems to get their work done, logging on to one system, then logging on to a different system, finding the patient again, the member, finding the member again, re-entering some information, double data entry. We see it both on the payer side and we see it on the provider side. It's a symptom of broken workflows. So I think that's another area where you want to say, can we improve that workflow? I think especially now with such workloads and pressure on workers to say, how can we at all make their work pleasant, but also more efficient by doing a better job integrating our systems and connecting and using these APIs to avoid doing what our users today. Basically, the way you look at this is what our users do manually today. That's what APIs are built to do. So now, I do want to say in there, and I think that maybe the next topic we want to talk about, I make it sound very easy, and that's not fair because it isn't. The technology is in place, the tools are in place, the standards are in place. It still requires organizations, health plans, healthcare providers to do the final stitching, to the final bringing things together, to activate APIs, to plug this API into that function. That requires staff in your IT department. And that tends to be a bit of a bottleneck, both on the plan side and the provider side. And that's something we ought to look at together to say that is if that bottleneck in our IT department causes the rest of the organization to have broken workflows, we got to fix the bottleneck. So I'm basically calling on healthcare leaders to rejuvenate their health IT staff and say, I know I need to have people in place to manage the system as I have in place. That makes sense. But now you also need to hire people and bring your people into your team or train people to say, start implementing interoperability, start connecting data systems together. It becomes a way to resolve that next bottleneck. And I think that's something we ought to be investing in right now. And an investment in strong IT staff pays itself back in efficient workflows and better quality of care or quality of work that they do. Dan, how do you look at that from your technical perspective?
I think it's it's also a double-edged sword. You do have organizations, especially when you get down to the provider side. It's going to come more down to system choice. What are you choosing to implement? And the heavy lifting on that IT side would have to be part of the questions that you ask prior to making your system choices as a provider. From a plan sponsor and or payer arena, I agree with you. There is that framework, that vision, at least laying out the context by which you're going to have the APIs handled. There's lots of ways to do it within the organization. There are technologies that act as message brokers. There's technologies that do that orchestration of services. Or, as you know, we've seen in others, they write it themselves. But you have a predictable contract between the language that you're speaking, or a common language, if you would. They call it a contract, but the language that you speak and the language that's being received. Overall, going back to your efficiency comment, it's not just efficiency, it's quality. You know, when you're moving between systems, error rates go up. When you're logging into multiple systems, your security perimeter has just been expanded. So starting to have the technology work for you instead of you trying to work with just the technologies is kind of a change in perspective that we're seeing the trends moving forward. A lot of larger global kind of organizations that are looking at health at a macro level are saying, you know, for healthcare to grow to its next evolutionary tier, these are the things that need to happen.
So as you guys are talking about this, I'm wondering, you know, there's the technology side and the IT staff, there's the care coordination staff, there's the various workflows. Before we move on to patient care and improving it, how do we get those folks to work better together to seamlessly integrate all this data?
Are you asking where do we start, Alan? Is that what you're getting at?
Where do we start, and how do we bridge from, you know, the very technical side of the to the practical, you know, I get into my computer and I look at my various screens, and how do I do that? And how do I not blame IT? And how do I work with IT? And how do we build kind of an ecosystem that really supports this new vision for how data is handled and managed?
I think it starts with requirements or business requirements, and a kind of step back and look at the workflow in the various, you know, the various constituents that you spoke about, but look at the workflows to say what makes sense. You know, for example, if the eligibility data, and we've got our standards today, does it make sense, instead of moving those files around, to not boil the ocean, but let's go after component, or break it down into components. And once you start and you get that first component or two, at least our experience has been, when we had the first component or two in place, you've now set your internal kind of construct where you're designing, you know, future functionality. All starts with the business, all starts with workflow, how people are using different applications and what would be of value to them, you know, during that part of patient care. Harm?
Yeah, I think that's rule number one. Start with the requirements. Couple those with your strategic objectives as an organization. What systems do you have in place today, and how do they meet your current strategic objectives, and how do you see that moving forward? I think the tendency in our organizations, both providers and plans, are to stay within the box that our IT partner gives us. That function exists, so I will use it. And I think what we're trying to say, well, you may need to start using something that does not exist within their box. And that's, I think, and where you'll notice that. So that Dan says, look at the requirements, and I agree with that. In addition, look at your staff, look at your team, see what they do. And you'll know very soon where the opportunities are in duplicate work, in coordinated workflows, I think faxing is another key. If you see any faxing happening, that means something is not working. And it means it's time to rethink and make things more efficient. So I agree with Dan, requirements. I would also very much involve your current staff, your care coordinators, your care managers, and listen to them, and they will tell you where the inefficiencies are and where they feel that better systems and better connectivity and better interoperability could improve the way they work. I think that's that I would couple that with requirements. The requirements, talking to your users. Those two will probably bring your story together.
Yeah, observe, and I agree with you 100%.
Observe.
I think that whole concept of they call it robots, but basically it's looking at repetitive processes and automating them. And again, going back to quality data has been a struggle that we've all had over time. And now we're going to get better data because it's pre-qualified before it comes into the system, where we need it, when we need it, and can also, from a security perspective, show that it's always secure. So it's least privilege. Who needs access to that data? They get access to the level of data they need to. But that's again, I think need to step back and also look at current system capabilities of vendors that you may already have versus when you are making a choice, the current system capabilities and roadmap for the vendor you're choosing. I think that's equally as important on a go forward basis.
So I hear you both saying that it's not just technology, it's the staff who use the technology, and it's building the bridges to encompass a grand work plan direction for the organization that looks at how data is used, what data is important, how you eliminate redundancies, and isolate off some of those challenges that are unnecessary. So on the health plan side, the technology clearly can make some broad differences. Could you both talk a little bit about what you think the implications are for healthcare, for providers, for outcomes of care, and for the populations that we serve?
We're going to start, Alan.
Why don't you go ahead, Harm?
Yeah. Before I answer that, and I will answer that, but before I answer that, I want to pick up on something Dan said. He twice now introduced the concept of robots, and I think Dan correctly said what he's talking about here is software robots. In other words, not little funny machines with eyes, but pieces of software that do things on their own. In IT, we call them robots. So even though they're invisible, they are working behind the scenes, but they're taking over some of our. So a chatbot, an automated person, an automated phone answering machine, even though we all hate them when we get them on the phone, they are an example of a robot that is not a built machine, but it's a software robot. We also call them bots frequently for short. Am I right about that, Dan? Can you also refer to as bots instead of leave out the row? I don't know, just call them bots. But they are emerging more and more, and they in many cases are invisible to us because they take care of some of the grunt work behind the scenes. And I think if we start, and many software companies today start deploying bots to help users get rid of some of their redundant automated stupid work, and so they can focus on the work that really needs their focus. So I just wanted to emphasize the use of that word. I really like the emphasis on the word robot in the positive sense. These are software bots that help us do our work faster and better. But with that in mind, getting back to Alan, your question on things that we see happening. So one of the things top of our list, should be top for everyone's list, is patient engagement. Many of these trends move toward more patient engagement. First of all, straightforward, sharing data, both plan data and provider data with the patient, with their family, and with their caregiver. That is a mandatory component of your strategy today. And rather than it being mandatory, I think make it something that you benefit from, make it something that's strategic to your organization to have a better stickiness and a better relationship and a better communication with the patient or their family, and do that through technology. Patients want access to their data. They often struggle with how to do it, but that's where this technology comes in, a better use of access points for patients and their families. So that's my answer number one. Alan, to your question, and the second one is care coordination. Care coordination, very much a component of value-based care, of population-based care, of care for at-risk providers. this is so much a team sport. And some of these care coordination teams are complex. They have multiple players, both on the health plan side and the health provider side, both on the hospital side and the ED. So it's very unlikely that these care coordinators, these people who work in care coordination, all are looking at the same information system and the same set of data. So this is why interoperability and data exchange really feeds into care coordination for complex multidisciplinary teams. So I think that's another strategic objective for health plans, to say, look at your care coordination. How can you feed those teams better data and allow them to interact and teamwork with their partners to become more effective? I feel that's another group of people that is waiting to be taken out of their narrow box and start playing in a much bigger box. So patient engagement and care coordination would be my two proposals to your question, Alan.
Dan, your thoughts?
As Alan, or I'm sorry, as Harm was talking, when he started going to think outside the box, I think one of the pieces that we haven't really mentioned is reuse of functionality.
Mhm.
And as we're seeing this innovation going on, where we've already talked about the process engineering that's underway, how we're trying to automate some of that process with these bots. One of the other kind of offshoots of this is reuse. So things that may be used by a care coordinator today may also be used by in a member self-service scenario tomorrow, or in a telehealth engagement.
Mhm.
So we're starting to see this crossover of functionalities that usually were within one discipline, starting to spread out, so that something that may be beneficial to a payer, there might be parts in there that are directly beneficial to that member. Also, from a provider perspective, we used the example earlier of the prior auth. Having been involved in that world for a long period of time, there are so many manual processes to get an authorization through, that it's just ripe for just a more better consistent application of technology, so that your results do not take human intervention. That's always been the goal, and folks are moving. I know there's outliers that fall out when you start looking at a member population. Well, we should be focused just on the outliers, not on the rest of that data set. And this lets us do that in more real time. So that's how I see it playing it to becoming more effective. The reuse, the outside of the box, the process engineering, and the automation.
So as we move to a broader series of questions, one of the things that I'd like to raise on behalf of our audience is, where does the patient or the recipient of care fall in all this? What rights do they have to privacy? I mean, we know that better integrated care provides better outcomes, but do patients have rights in this about what information they want shared, they don't want shared? They don't want one doctor they see talking about what you might have talked to another doctor about. So can you both talk a little bit about where patients fall in all this and their families?
Arm, you want to start?
Okay. Yes, definitely. Fully control. It depends a bit on state regulations. I have to start by saying that, but let's assume most states, as far as I know, are opt-out states, so that the assumption is that the data can be shared between providers. But the patient can always opt out of that assumption and say, I am going to specifically request that I do not want my data shared. Every healthcare organization and every health plan is able, should be able, will be able to support those opt-out requirements. So if a patient tells their provider or tells their plan, do not share my data, that will be withheld and will not be shared. Of course, in a complex environment, this is complicated. What I would like to say there also is that in my experience, the number of patients who opt out is relatively small. It's approximately 3%, but certainly the technical capability, and with every information system, the opt-out options exist. So you're able to indicate this patient doesn't want their data shared, which will then hold back that data. Dan, what's your technical perspective on?
It's mixed. So I see it a little bit differently. I think there was a path that was going down, more of opt-out. COVID hit, and there was a loosening of information exchange. Things that were considered health information were now shared or required by employers, by other entities, for you to fly. You know, your health information was being required. So there was a new balance kind of struck. I think it's going to move further where it'll be more granular as patients are empowered more and better access to their health information. You're going to see similar to what we've seen in telehealth, where you can share what you want to share with that provider. That could be lab results, that could be other determinations, but you get a little bit more granular in letting the patient, instead of a blanket opt-in, opt-out, unless you're in a break glass scenario where somebody needs to have access to that data because of a critical condition. The patients, I see it as getting more control as the systems get more member-centric.
Great.
So do you think this has a patient education component to it that has somehow to be addressed?
Sure. I mean, think about that. I mean, obviously, yes. I'm not sure what I can read that questions multiple ways. As I think I can read this question either does this mean the patient needs education, or does this mean the patient will receive more education? And I think in both cases, certainly patients will needs to become more engaged. But I think you're saying, is there a patient education need? Do we need to educate patients and families more to the role that they can now play, given this more, given this access? I do think so. And I think in many cases, it's the provider's role to encourage patients to activate these functions. And I see many patients are using the fact that they have access to their data. Let me give you one scenario here. When you get your lab work done or any old test done, you can get access to those results almost immediately. As soon as those results are available, you can look them up in your portal or in your app or whatever method you have to access those results. That didn't used to be that way. There used to be a certain period of time by which your doctor or clinician would be able to look at the results first and let you know first. That was important to doctors, and it is important. I think many doctors feel very strongly about that. It's their role and their job to let their patients know. The law, however, says no right away, immediately. I think that was a mechanism by which in this case, ONC with their advisor says, we understand the role that physicians want to play, but yet at the same time, we think that patients are better served if they have straightforward access to their data. Yes, that requires education. That means patients now need to be aware that they can see their data as soon as it's available. And that sometimes means they're reading things they have questions about and should be talking to their provider about. Those things I think are new, but and will require some education. I'm quite optimistic, though, that at the end of the day, most patients will take that role and will become very active participants in their care, as they are today. I'm not sure if I answered the question, but I tried.
Your thoughts, Dan?
I think education is to Harm's point. It's a broad statement. I think it's the lens by which we look at the information that we're providing to ensure we're adding value. So if we're presenting just in the same way, if you have lab values, what's normal, what's not, and then, okay, I want to make that actionable. What can I do to change it? Or what do I need to do? I see that there's in more of the chronic care conditions, there's been more of a It's almost like a concierge service where you're now speaking a whole different vernacular with all different words, specifically oncology, and you're starting to see the rise of folks that are becoming the kind of translator and helping folks through a process of understanding. So on one level, your normal, call it your user manual for the person, things that you become more accustomed to seeing in your lab, your health records that as provided within your particular payer's portal, there's value there. There's also, you're starting to see more and more where instead of just telling you something, they're showing you what's more actionable. And that's just part of the evolution of the information systems.
Great. I think that's key. And I think what we're talking about here is we're evolving as we move to a new systems of care, new processes. We're developing partnerships that include, technology, they include health plans, they include providers, they include patients, their families, and recipients of care probably need to be at the center of that universe. And we try to drive outcomes that guide us to better integrated care and better well-being. One quick question before we run out of time that we also have is the question about social determinants of health. Either of you want to make some comments on how this new interoperability and data sharing may impact social determinants?
I'll start and hand it off to Harm. I think as you start to look at, again, that longitudinal view of a patient, there were, a number of touch points for SDOH measures that were just assumed, and there's different ways that we went about it. We're starting to now see more touch points going down that view because we have access to more data in real time. To the point that was made earlier, the latency of that data is better. So we have the better chance of having an intervention prior to an event. And we're interacting, for example, I used the example the other day with medications, changing that curve for compliance and adherence, where you're showing the benefit and having that check earlier on to know that the patient didn't have food in the house. That's why they didn't take the medicine that said to make sure they ate when they took the medicine, or they had a transportation need, or there was some other outlying need. I think we're going to see more of that again during that as part of the patient ecosystem, looking along the longitudinal view of that patient. Harm?
I thank you. And I want to answer it from two sides, social determinants. One is from the data side. How do I know? How do I know about this patient? What do I know about this patient in their social and the life circumstances area? And second, what do I do about it? What do I do differently than I would do today? And both include the need to step outside your current system. So how do I know about it? A lot of social determinants are driven by outside data. We are able today to collect some social determinants inside our EMRs and maybe also inside our claim systems, but the reality is that it's fairly narrow and only restricted to the most obvious glaring cases of people who are in need of social determinant and circumstances care. Homelessness, for example. But it doesn't capture a lot of the other things we need to know about patients. And I think those data sets come from outside systems. They come from census-based systems, they come from other information systems. And the way to get access to the information is again through APIs and outside interfaces. That's on the data side. Now on the what do I do about it? Of course, there are now a number of organizations that connect patients and caregivers with community benefits organizations that provide food, transportation, education, housing, partner support, many types of organizations, large and small. And there are these organizations that help connect you as a caregiver to those organizations and then help you connect the patient to those services. Again, that's not one information system. That is a multitude of systems that are all needing to be connected and all need to share data. So these organizations need to know about the patient, the request, their need, and hopefully send you information back about the response, the effectiveness. So I see a huge need for systems interoperability so that we can better address social determinants, both on the understanding the patient side, but also on how do I now impact that side. Both will require data exchange and interoperability. That's why I'm so bullish about this technology, that we can start doing these things that would used to be, restricted by the systems we use.
Great. I think we're almost out of time. I think what the key here that I've been hearing is that we have an opportunity for taking increased data, increased coordination amongst that data, and translating into actionable ways to improve health plan function, providers function, and the outcomes for those that we serve. So I think that this has been very enlightening to help move us forward to think about those challenges. And we as InfoMC are happy to be available to answer more questions. We're happy to engage in further dialogue around this if we can be helpful. You'll see on your screen contact information, and we welcome the opportunity to move forward to foster further discussion. Ron, is there anything else you want to add on your end before we wrap up?
Well, we do have one question from the audience out there. How can we use patient-reported data for SDOH status?
That is a great question. Let me see. Patient-reported data is a huge category, right? That includes surveys, patient-entered data, but it also includes data collected from your smartwatch or patients, data collected from a home devices inside a patient's home, which is a huge topic. But let's take it specifically to the social determinants. I think that, first of all, I'd say yes, that patient-reported data will help a great deal in increasing our understanding of what patients' needs are. And I would love to find surveys, questionnaires, assessments going directly to the patient and their caregiver to have a better understanding. I think some systems today provide that, but I think being able to reach into giving patients access to an ability to send that data in is super helpful. I would welcome it, and I think it's a great idea.
I think we're
Dan, am I skipping something there?
Yeah, no, I think we're also going to see more of the data telling the story. We have data that's coming from all over the place, and that data, we used to call it data mining. We're seeing more machine-based learning being utilized to find common trends, to find those gaps in care, and then to your point, Harm, include that patient voice. Whereas they don't have to repeat it 10 times. If the systems are connected, they say it once and everybody can look at it with their lens and make the determinations that would best affect that patient encounter.
I love it.
Great. Well, thank you, Harm. Thank you, Dan. And Ron, thank you for help facilitating this session.
Thank you. We appreciate your time today, as we appreciate all the people that attended for taking time out of their busy schedule to join us. Just a reminder again that the slide deck and recording will be posted on the ACAP website by tomorrow morning. So thanks again and stay safe.
Thanks, everybody.
Thank you, everybody.
Bye.